Good afternoon. This is Kemal Erkan from American Surgery Center. Today is February 3rd, 2023, and this is our Bariatric Friday event where we discuss patients who are going through bariatric surgery or people who may be struggling with morbid obesity. And for that, I have Dr. Isaias Irgau with me. Dr. Irgau, how are you doing?
I'm doing great, Kemal. It was great watching your previous session, conversation with Governor Carney. That was fantastic.
Thank you. So today we are going to discuss risk and complications of bariatric surgery. So because we have done this so many different times, I try to kind of see it from different ways. And when we say risk and complications, so the definition of risk is a situation involving exposure to danger or expose to danger, harm, or loss. So when you come from that angle, it's a little bit different because, like, I struggled with this one a little bit, Dr. Irgau, and I'll tell you why. So when I look at the risk and complications, I know we want to talk about surgery risk and complications, but the not doing the surgery risk and complications is maybe a lot heavier, not a lot heavier, much more heavier. So that's something that I wanted our patients to really understand. So yes, we are going to talk about the surgical risk and complications, immediate one, midterm, and then long term. But not doing the surgery has a bigger risk, and which we discussed the benefit of bariatric surgery. And this is something that I wanted to make sure that we kind of like highlight and emphasize for people who are following us.
That's actually a great way to frame this discussion, Kemal. Very, very important. You're absolutely right. Risks and complications are things that can happen, during a particular intervention or treatment, right? But the treatment is essentially a choice, a decision, right? And not taking the treatment is also a decision and a choice, right? And then we have to look where each of those roads lead the person, right? Where does a person end up after they have surgery and lose weight, right? What are the risks within that road? And where does a person end up if they don't have surgery and continue in the course of morbid obesity? Where does that road lead them? What are the dangers that are facing them, right? Well, let's look at the most striking danger, which is death, right? That's what we fear about surgery, treatment, right? Is there a risk of dying, right? Well, with any option that we make, with any treatment, obviously that possibility is there. It's never zero, Kemal, right? But if you look at bariatric surgery, the way it has been refined, the way it has been prepared in modern programs like ours, modern programs that have been certified as centers of excellence with very experienced surgeons, the risk of death is way lower than 1%, right? Lower than 0.1%, right? Now, compare that with the risk of shortening one's life if a person was continue to stay morbidly obese, right? We know that with morbid obesity, all the data show it come out clearly, a person's life is cut short. A person is less likely to achieve their life expectancy, right? If they stay morbidly obese. The higher the body mass index, the shorter the lifespan. So there is no question there. It's not about a 1% issue. It's a 100% issue, right? If you stay morbidly obese, you are not going to be living the way you are expected to be living compared to the life expectancy in our society right now, right? That is that. So when you have these stark figures, you know that the choice should be really clear, which is losing weight with surgery is far more beneficial, much less risky than staying morbidly obese. Right? Having said that, it is obviously very important that we educate our patients about the possible risks of surgery. We have that obligation as healthcare givers that every time that we provide a treatment, every time that we recommend a treatment, we have to be able to inform, educate our patients the benefits and the risks. And that is obviously the session today. We will be talking about that. Now, as you correctly said, risks and complications are very different from consequences, right? So a risk, for instance, could be bleeding or blood clots, as we will speak, right? But a consequence might be excess skin, for instance, right? Losing weight, that's a known consequence of the surgery, right? If you're losing 100 pounds, you will have excess skin. That is not a complication of the surgery. That's a consequence of the surgery because of what it does, you lose weight, right? A complication is something very different. We're very happy, obviously, to report that in the way we perform bariatric surgery right now, the risks are very low, particularly the serious life-threatening risks are extremely low. And that is because we focus on prevention so well. And we've been very, very successful in preventing these serious complications in the vast majority of patients. Nevertheless, of course, today's session, we will be discussing them.
Absolutely. So that actually, again, because we do these in smaller sessions, shorter sessions, so that it's not the entire process that we are discussing. But even for us, maybe this is our fourth or fifth time we are maybe repeating the same topic. However, the way that we are processing, it still brings up those unanswered questions or maybe not addressed concerns because someone, when I was maybe preparing for this, I'm seeing it differently than the patient standpoint. I'm like, well, I'm talking about risk, but then, well, when they have to live with BMI 60, first of all, they're not going to live that long. So then that's why I was kind of like just having my own debate there. So then I wanted to share that with you and with our audience. Now, going back to the risk and complications, so if you can actually let us know what are the immediate risks from the surgery, and then we'll continue from there.
Absolutely. So it is important to talk about the immediate risks of surgery. Immediate meaning things that can happen, within the first 30 days or first 45 days after the surgery, right? So I want to focus first on the potentially serious complications, the complications that could be potentially life-threatening, okay? And really, there are three major complications that can happen with any type of major bariatric surgery, right? The bariatric procedures that we do right now include gastric bypass, gastric sleeve, duodenal switch, and to a less extent, the gastric band as well. And to some extent, the complications that I am going to talk about right now can happen to any one of them, although they may be much more pertinent to gastric bypass, gastric sleeve, and duodenal switch, as opposed to the gastric band. So the first one is infection, okay? Infection, what type of infection? Internal infection. We're not talking about superficial wound infection. We're talking about internal infection. Again, this is extremely rare nowadays, right? And it happens, or it can happen, if there is something called a leak, Kemal. And we've talked about a leak, and patients talk about a leak, but it's important to make sure people understand what this means, essentially. Essentially, when you do gastrointestinal surgery, the way we do it for bariatric surgery, you are cutting the stomach or the intestine, you are stapling the stomach or the intestine, and you are connecting together the stomach and the intestine to some variability, right? When you make this cutting and this connections, the wounds have to seal with complete integrity. In other words, we cannot have even a bubble of air go through that wound. With that complete sealing of the wound and integrity, there is no problem. But what if there is a leak? What if there is loss of integrity of that healing? Substances that are supposed to stay inside will start leaking out. And a good way to understand it, to have an analogy, Kemal, is to think about the pipe system in a house, for instance, right? We have pipe systems running around inside the walls of the house. Something enters at one end and it's supposed to get out at one specific end. You don't want the pipe to have any defects in the middle, because if it does, then stuff will leak out, right? It's the same thing with our digestive tract. It's one long pipe that starts from one end and finishes at another, right? Stuff goes in through one end and then gets out from the end.
Mm-hmm.
It's sealed that way. There is nothing that should be leaking. If it does leak, then you will have gastric juices, acids, bacteria leaking out and creating an infection, right? This is what a leak is essentially, right? And it is extremely rare nowadays with the way we do surgery, Kemal. It's less than 0.1% in our practice, right?
I was going to say that. So I don't, since 2001, I don't actually, 2021, I don't see any.
None, you're absolutely right. That's very, very few in between. Now, there is different extents of this, obviously leading to different outcomes. Of course, it is a serious condition. There is no question about that. But early identification and early treatment leads to a good outcome, right? And one of the things we do is we educate our patients on telling us if they're not feeling well or doing well, because there are signs of a leakage, right? What are the signs of a leakage? Well, the patient, first of all, are not going to feel well in general. They're going to feel sick. They may have nausea and vomiting. They may have a fever, right? They may have chills. They may have abdominal pain. When any of those things happen, they need to let us know, because this could be the indications that the leak is happening. And what do we do? Well, we bring them in, okay? We provide them antibiotics, and we do tests to see if there is a leak. And if there is a leak, sometimes the treatment might be just avoiding food, right, for a while, and giving nutrients through an IV and antibiotics, and that will actually seal by itself. Sometimes we have to intervene by placing a drain or doing surgery. But even though it is a serious condition, it is fixable as well. That's the other thing that is very important to understand. We have to educate our patients about possible signs of this so they can alert us in time. The worst thing that can happen is for this to drag on without anybody intervening, right? So leak, something that can happen with any of these major procedures. It's extremely rare, but it can be serious. It's preventable with the way we do surgery, but also it is eminently treatable.
Exactly. So now when we are talking about the risk, these are the short-term complications, like 0 to 30 days of post-op. So we covered the leak.
And then there are a couple also. I want to add to
dehydration is something that we see maybe a little bit more, right?
What's that again?
Dehydration.
Yeah, dehydration. So right now I am talking about the more serious complications, and I want to add a couple more before we go to the less serious ones. So we've talked about leaks, infections. Again, they're very rare. They can be serious. They can be treated very well, and patients need to be educated about signs and symptoms of that, okay? Another potentially serious risk, Kemal, is blood clots, formation of blood clots. Now, this can happen with any type of surgery. And what it is exactly is that when blood flows inside our veins, the blood that starts from the away from the hearts and then going towards the heart, the venous blood, right? It has to flow continuously. If, for instance, if flow is interrupted, then it can coagulate, it can form clots, right? And these clots can form generally in the legs, for instance. And what is the danger of this, Kemal? The danger is that when these clots form, they can travel all the way from the legs into the lungs, and they can block perfusion or blood flow to the lungs. That is a life-threatening condition, because then you're not able to exchange oxygen. When the blood clot travels to the lungs, it's known as pulmonary embolism. Okay? Now, blood clots can happen for a variety of reasons, right? One of the reasons blood clots can happen, Kemal, is surgery itself. Having general anesthesia and having any type of surgery can increase the risk of blood clots, right? There are other factors as well. One of the factors is obesity. So our patients, by default, are actually at higher risk for blood clots than other patients, because obesity itself is a risk factor. Another risk factor is
taking care. Like it's like the blood clot is not a risk of. It's not initiated from the surgery. It's the condition that patient has.
Absolutely. The risks of blood clot is there with any surgery, but when you, for instance, start off by being obese, older than a certain age, having a history of blood clots in the past, all that are risk factors that would increase the chances of blood clots. So because bariatric surgery deals with patients that are morbidly obese, inherently bariatric surgery does have a higher risk for blood clots. But this also has created an opportunity for us bariatric surgeons to seek ways to prevent blood clots. And we have them. We have excellent ways for doing that. the best way to prevent a blood clot, for instance, Kemal, is to get the patient to get up and walk early after surgery. And guess what? In our program, patients start walking within an hour or two after surgery, right? Because of the way the surgery is done, the patients have less discomfort and they are able to get up and walk. Because less narcotics are used after the surgery, the patient's mind clears up very quickly and they are able to get up and walk. So there you are, one important way for preventing that. The other two methods that we use to prevent blood clots are give the patient blood thinning medication before the surgery, and in some cases after the surgery for up to 30 days after the surgery, right? To thin the blood so that the chances the blood clots are less. And then the third way in which we minimize the risk of blood clots is to put special boots around the legs of the patients. So when they are immobile under general anesthesia, these special boots will pump the blood in the calves of the patients to get the blood to circulate better. With these methods, we've been able to decrease the risk of blood clots in bariatric surgery to levels that are lower of those thin patients undergoing other types of surgery, right? So this is why bariatric surgery has achieved such a high level of quality now, because it really works in centers like ourselves to prevent those potential complications. Now,
so it always comes down to the prevention. So because
absolutely.
One of the things that we do from the care coordination and daily case conferences, this is one of the many items that we are looking for. And it's not just one person or one position is looking for it, like starting from the surgeon to the nurses to the surgery center. So because we don't want that potential complication to be missed, because it's really not like, I mean, what you said is true. Patient needs to be walked and other things, but if the patient is not the right patient for that setting, meaning that, I'm going to rephrase that, if the patient was not prepped properly for the surgery, so because our screening process is 2 to 3 months at a minimum, where we are actually looking at what medications they take. They get the cardiology clearance. We look at their hemoglobin and other. Like a lot of times, patients don't know that they have diabetes, or they are not in treatment for diabetes, and then we actually diagnose them because of all the screening process that we go through. So I think risk is there, but how we actually handle that risk, how we are preparing our patients for risk, that's the most important.
Absolutely. So we know what the risk factors are that will increase the risk for blood clots, right? And we act appropriately. So for instance, I do remember, was it yesterday or the day before in our case conference, one of the nurses said, Dr. Irgau, this patient has factor V Leiden, right? This is a genetic abnormality that increases the risk of blood clots. And that's important information for us, because guess what? That patient will not only have blood thinning medications, on the day of surgery, but we will ask them to take that blood thinning medications for 30 days after the surgery on a daily basis. And that will help them decrease the risk of blood clots tremendously. Or if the patient has had a previous history of blood clots, or if the patient has a family history, or if a patient has a body mass index greater than 50, we also know that can potentially increase the risk of blood clots to a higher level. So we would prescribe the special medication for a patient to go home with for up to 30 days. So blood clots essentially is a serious problem that can happen with any surgery. It can happen even more with bariatric surgery because of the risk of obesity and blood clots, but it's eminently preventable. Now, it doesn't mean this prevention leads it to zero. Of course, there is no such thing in medicine, but it can bring it down to very, very, very low levels, so that this is not something that...
So this is also maybe a good time to reemphasize why we want our patients to lose a certain amount of weight.
Absolutely.
And how we saw some discussion the other day in the support group. Some patients are doing longer diet than the others for the prep, because it's all about the prep. So if the patient's BMI is not extremely high for morbid obesity, but not extremely high, then they may be okay with 2 weeks special diet. But if they are way higher than our normal limits, we may ask them to do 3 weeks robot diet, because the whole thing is about reducing the potential risk. Because if you don't do any of those, everything is a risk.
Absolutely. Right. Come on, we're talking about complications today. I can tell you, for every complication that we'll talk about, the higher the body mass index, the higher the potential for complications. So reducing particularly very high levels of obesity and BMI, reducing them to as low as possible before surgery actually greatly enhances the safety of that surgery. So there is no question that when sometimes we ask our patients to do 2 weeks or even 3 weeks, and very, very occasionally even 4 weeks of preoperative diet preparation, it is actually a lot for the patients to go through, but it increases the safety of that procedure immensely, essentially. So there is a very important rationale for wanting to do that. Mm-hmm. So we talked about leaks, right? We talked about blood clots. The third one that could be potentially serious, Kemal, is bleeding, right? Well, bleeding has been associated with surgery from the inception of surgery, right? Because with surgery, what we're doing is we are cutting into tissues, and when we cut into tissues, bleeding occurs, right? So bleeding can certainly happen, and we're talking about internal bleeding. Now, this can happen during surgery because there may be a damage to a particular organ and bleeding can occur, right? Or it can happen right after surgery as well, right? The more common type of bleeding is the one that can happen right after surgery. Mm-hmm. And because of what I just said about the blood clot, because we put patients on blood thinning medication, there is actually an increased risk for bleeding as well. But again, it is a calculated risk, meaning that we are able to mitigate that with preventative measures as well. For instance, the timing at which we give the blood thinning medication before surgery is done at such so that when there is a higher risk for bleeding at that particular time, the patient is still in the operating room and the surgeon is looking at the organs to see that bleeding is not increasing.
That's already too late.
Right, absolutely. So when we are putting together tissues that we have cut, very often we use special material to buttress those tissues to prevent bleeding. So again, prevention is the way to go, right? But the more important thing about bleeding, Kemal, is that if bleeding were to occur, a serious type of bleeding, it occurs usually within the first 1 or 2 hours after surgery when the patient is being monitored very intensely, right? We have our patients under very intense monitoring in the first couple of hours, 3 hours, 4 hours after surgery. That is a time when we want to pick it up if it happens again.
And that's why the expertise is extremely important, not just from the surgeon standpoint, but for our nurses. Most of the time, all they do is bariatric. So I don't believe there's any other nurse who would know bariatric better than our nurses if they've been with us for more than a year, because the chance of them dealing with the bariatric patients on a daily basis is 80%. So therefore, their expertise is going to be a lot better than anyone else. So this is, from the prep to the surgeon to the after surgery, it's all about the expertise.
Absolutely. So early recognition of the problem and early intervention, again, is very critical here, right? So sometimes blood transfusion may be necessary, sometimes reoperation may be necessary to fix the issue. But again, it is a problem that is extremely rare as well. So 3 potentially serious complications that can happen around the time of surgery, Kemal, but that can be prevented to a very, very low level, but even if they happen, they can be taken care of and fixed as well, right? So serious in their potential, but eminently preventable as well as treatable. Again, the statistics we're bringing here are extremely low, but nevertheless are things that can happen. So now I want to focus a little bit about things that can happen in general, right? When you mentioned dehydration, for instance, Kemal, that's absolutely right. Nausea and vomiting can happen as well. These are things that can happen with any type of gastrointestinal surgery, Kemal. And again, we focus on prevention as well. It is amazing actually how many of our patients will come to me and say, hey, I was on this and that Facebook chat and I kept hearing all these patients having nausea and I didn't have any, and I was wondering whether I had the right surgery, right? Because they hear so much. Well, the reason because of that is, Kemal, we have again a protocol that leads to minimize of these symptoms as well, okay? And that's because of the medications that we are able to use around the time of surgery, and some medications we are able to avoid, like narcotics, for instance, right? Narcotics are pain medications that have one of their consequences is nausea and vomiting. Well, if you minimize narcotics because you're able to take care of pain in different ways, then you're going to minimize the risk of nausea and vomiting as well. Nevertheless, these things can happen, and occasionally patients have had to be brought into the surgery center for IV hydration, where we give them intravenous fluids to just prop up their hydration. But importantly, education is also important, right, Kemal? Because patients need to understand that they cannot grab a glass of water and drink it all because they are thirsty after surgery. They cannot do that because their stomach is very small now, right? So if they cannot do that, what they have to do is they have to prevent thirst. And the best way to do that is to just sip little amounts of water frequently and continuously. Exactly. So that's what we tell our patients: carry some water with you everywhere. And if you're not asleep, if you're not talking, you are sipping water. Just wetting your mouth with a little bit of water continuously can actually lead to good hydration. And we have to educate our patients about ways to measure hydration. If their mouth feels dry, of course, if their urine looks very, very concentrated, then it means they're falling behind on their hydration. So we put a lot of emphasis on educating patients about the importance of hydration early after surgery, right? There are a couple of complications that are peculiar to each one of the procedures, and I would like to address those, Kemal. And I will start with gastric bypass. Now, with gastric bypass, we connect the little stomach to an intestine, right? And that connection is vulnerable to something called ulceration. In other words, that connection does not heal very well, or after it heals, it can form a wound known as an ulcer. Now, the chance of ulcers occurring are much higher if a person is a smoker, or if they are taking medications like aspirin, the so-called NSAIDs, non-steroidal anti-inflammatory drugs, things like Motrin, Aleve, Excedrin, right? All these medications can increase the risk of ulceration. So patients who have gastric bypass are instructed to stay away from this type of medication. They can take Tylenol. Tylenol is okay, but Motrin and Motrin-like medications are not good. And most importantly, obviously, we have a requirement for patients to stop smoking if they were smokers before surgery, but obviously we really recommend and educate them about not picking up smoking again after surgery. One of the consequences of resuming smoking, among all the other consequences of smoking, Kemal, is that if a patient has had gastric bypass, they are likely to develop ulcers. And ulcers can bleed, they can lead to scarring, and they can perforate, right? I had a patient that had been operated about 8 years ago, Kemal, that came in very sick the other day to the hospital because of an ulcer, right? And of course, there is a history of smoking. There is a history of heavy drinking as well, which did not help the situation. But ulcers can be very, very serious problems. Now, this does not tend to happen with the sleeve, but it can happen with gastric bypass. Another thing that can happen with gastric bypass, even in the long term, Kemal, is that because we are rerouting the intestine and taking it away from its natural position, the intestine can twist or enter in some pockets known as internal hernia, and that can cause bowel blockage that requires emergency surgery. So internal herniation, bowel blockage, more likely to happen with gastric bypass, right? And this can happen up to 10 to 15% of times, requiring surgery after gastric bypass. So this would be more particular to gastric bypass. Now, if we
during the process, we are educating our patients with all these, so that like smoking is one of the no-nos.
Absolutely.
They should even entertain that.
Yeah.
Because that can actually complicate, even if like other procedures or other things, it's already complicating. So at this point, this life change journey needs to be fully implemented. Otherwise, the benefit is not going to be there fully.
Absolutely. And what would be more particular to the gastric sleeve? Probably the heartburn or reflux would be more peculiar to gastric sleeve after the surgery. So now patients who didn't have heartburn can develop heartburn afterwards. Patients who had some heartburn can worsen their heartburn, but similarly, patients who did have heartburn, their heartburn may go away after gastric sleeve. So just because a patient does have a history of heartburn, it doesn't mean they should avoid the sleeve gastrectomy, but they should know that there is a potential for the heartburn to worsen and require medications afterward. Now, what is that? What is the cause of that? Well, it has to do with the fact that after the sleeve gastrectomy, Kemal, the stomach not only is small and banana-shaped, but also it's stiffer, which means that the pressure inside it increases, which means that acids from the stomach are potentially able to be pushed back up into a low pressure area, which is the food pipe. And that's what heartburn is acid coming into the food pipe. And that may require medication. As I said, this is not universal. In fact, there are patients who did have heartburn before the gastric sleeve, and then after the gastric sleeve, the heartburn may go away. Perhaps they had something called a hiatal hernia that we are able to fix at the time of surgery, and that leads to resolution of the heartburn. Now, are there situations in which the heartburn can become so difficult to treat that patients require a different surgery to fix that? Yes. In a small minority of cases, some patients who've had a gastric sleeve can develop heartburn. They may require changing their sleeve into gastric bypass to rescue the situation. But the number of patients who require this is so small that just having a history of heartburn should not be an automatic reason for requesting the gastric bypass, because the gastric bypass also has potential risks that I just mentioned, including the ulcer and the twisting. Now we move on to the duodenal switch, and there are complications related to the duodenal switch. As people may know, the duodenal switch is almost like an extreme type of gastric bypass where a much longer portion of the intestine is bypassed. And as a consequence, patients can develop diarrhea that may be difficult to treat, or they may develop very severe malnutrition, very severe, extreme malnutrition. And if that is the case, they may require reoperation to shorten the bypassed segment of the intestine. So
for the duodenal switch, kind of like the revision, like, because we are doing the second stage of that, we are not doing
absolutely. So duodenal switch can be done either as a second stage procedure after a person has had a sleeve gastrectomy, or it can be the first procedure where the patient will have some type of sleeve and the duodenal switch as the original procedure, essentially. So in summary, essentially, when we look at the major complications that could happen to any of those procedures, we've talked about leaks, we've talked about blood clots and bleeding, and these are potentially serious complications. The good news is that they are very, very rare. If they happen, they are treatable, right? We can take care of them, we can fix them. Obviously, patients need to be educated about potential signs and symptoms of this. Then, of course, we talked about complications that could be particular to each one of those procedures. Now, this is not, of course, a comprehensive list of potential complications, because such things cannot be achieved in such a short session.
If you don't mind, because we do have a specific session for nutrition, but this is one of the long-term complications. But again, I'm just thinking like it's not a complication if they follow, like just an example, and I don't know if, like usually I end up giving an example from one of the family members. So far, no one is complaining.
They are very kind.
So my brother-in-law I was with them last 2 weeks.
Mm-hmm.
And do you remember how you were surprised that when you find out I wasn't taking any multivitamin?
Mm-hmm. Mm-hmm.
And I just transferred that response to him. Like, oh, how dare you are not taking? he was kind of complaining about certain things. I'm like, look, I mean, I'm not getting enough vitamin, and are you taking multivitamin? He's like, no, and he's 61.
Mm.
So, and then after explaining a little bit, He's like, oh, okay. So then I actually left my bottle there. So he started taking that. And then just the other day I was talking to him, and then he said he's feeling better, and he feels like if he has more energy. So certain things we just need to follow what instructions are given, because I don't think there's any other program like surgical program or medical program where we are giving this much instructions with so many different people with our multidisciplinary approach. So the thing is, we need to follow them, because you won't have nutrition issue if you are taking vitamins. You may still have, but if you don't take the vitamins, then you are going to have that issue.
Absolutely.
One thing with that is, and if you can explain this next one a little bit, dumping is one that it's kind of like, for whatever reason, it's more popular, not necessarily more, it's not happening a lot, but people like to discuss that more.
Yes. So in general, it's really a cardiovascular response generated by something that happens in the digestive tract. Okay. After gastric bypass is the time in which it is seen much more commonly. So what happens is that with gastric bypass, we just have a small portion of the stomach, right? And then the intestine is directly connected to it. So imagine before gastric bypass, the food would go into this larger stomach, and it is slowly emptied into the intestine from it, right? So for instance, if a person had a piece of chocolate, for instance, that piece of chocolate would find its way into the stomach, and then the stomach will empty little bits of that chocolate slowly to the intestine. And before it reaches that lower portion of the intestine, the chocolate will have been processed in many ways, right? But now we're attaching this lower portion of the intestine directly to the upper portion of the stomach. So it means that this piece of chocolate, without any processing, is entering the intestine directly.
So that bypass is bypassing the stomach.
It's bypassing the stomach and the intestine. So this big load of pure sugar entering the intestine creates all sorts of reactions. One of the reactions is actually to raise the insulin level in the bloodstream, right? It raises it to such extent that sugar is wiped out from the bloodstream, and that person can become hypoglycemic. Another reaction is rush of a lot of fluid into the intestine, draining the fluid from the rest of the vascular system. So the person will feel dizzy, they may feel disoriented, they may feel sick to their stomach, they may have vomiting, they may have diarrhea, and they may have intense cramping. So with all these symptoms, it's a very unpleasant thing. And that happens specifically when a person who's had gastric bypass consumes refined sugars, right? And you can see it they can see them in front of your eyes after they've eaten. They feel ill, they sweat, they feel dizzy, and they have a lot of pain essentially. And that experience is so badly memorable, Kemal, that they will never touch a piece of cake or chocolate afterwards because of that reaction. So that is really what we talk about when we talk about dumping syndrome. So anybody who's had gastric bypass, Kemal, cannot, at least in the first few years after their surgery, have refined sugars. And that is something that happens with gastric bypass. It's rare, never seen really after the sleeve gastrectomy. Much more common after the gastric bypass.
This is also why we have, after the surgery, we have set appointments up to 5 years, either with the surgeons or with the nutritionists or with the primary care. This is why follow-up is important, because it's not all about the surgery itself. Just like preparing for the surgery, it takes a lot. After the surgery, adapting the new life, adapting the changes, it requires the support. And if you don't have the right people there, then you're not going to get the proper support. So even, after our intermittent fasting session, one of our employees here came up to me and I said if she could do the diet with me. I'm like, well, sure, why not? So now that's an extra responsibility, right? So I'm actually following the diet a little bit better. So because you have someone who's working with you.
Keeping you accountable. Yeah.
So the same thing, the nutritionists are the best to address some of these issues after the surgery anyway, but then patients shouldn't miss their, I mean, do you remember that patient last night? So for a different reason, we were checking this patient with Dr. Irgau, and the patient BMI, if I'm not mistaken, was 46 or 48. And the surgery was 3 weeks ago, 3 or 6, not weeks, 3 months or 6 months, and maybe like let's say 6 months. Her BMI is down to 29.
Yeah.
That's like, where do you get that?
Huge change, yeah.
Right. So that comes with some responsibility. Responsibility of adopting and following the guidelines that's given, instruction that's given.
Absolutely.
And when you have questions, then you watch one of these.
Yes.
So then, and then you can, it's not, nothing is that simple.
Of course.
Nothing is that simple. And this is true for those who are not dealing with morbid obesity, but this is more true for those who have morbid obesity. So, Dr. Gao, I don't know if there's anything else you want to add, but I think we covered it very well.
We did, Kemal. As I said, this cannot be a comprehensive list, but it is an introduction, particularly of the more serious complications. And most importantly, Kemal, to reassure patients that the risk for these problems is really extremely low in very mature, experienced programs where you have surgeons with years and years of experience. And also you have programs that have been certified as centers of excellence because their outcomes have been much, much better than the average, essentially. And that's the bottom line.
Absolutely. And this is the right place. American Surgery Center and CHRIAS are the right organizations to get the operation done and have the best surgeons, best medical staff, best nurses. And that's the only way that this can be done right. So, well, thank you so much for joining us, Dr. Gao. Thank you again. And we'll be back next week. Bye-bye.
Thank you. Have a great weekend.